Hi, my name is Tim Scialla, and I am an attending in the Division of Pulmonary and Critical Care, and I've been asked to give you a lecture on the overview of circulatory failure, pathophysiology, diagnosis, and therapy. Usually when someone titles a talk as an ambitious overview, that is code for going over the designated period of time that I've been allotted. So hopefully you'll be able to stick with me for this. If not, I have compartmentalized this talk into 4 different components so that you can watch them independently. Just so you know, as far as the way I have created the content for this lecture, all of the content and the images from that content are derived from the book chapter from Critical Care Medicine, Principles of Diagnosis and Management in the Adult. That book chapter is available through Clinical Key, so you can get the PDF from Clinical Key through the Duke website at the library. Also, there's an excellent review article on circulatory shock from the New England Journal in 2013 that also I used heavily to make this talk. In fact, if you don't like listening to lectures, now's the time to shut this off, because you can go ahead and just read all that content you want. But for those who want to stick with me, I would encourage you to go back to that those 2 resources to reinforce some of the more difficult concepts. The other 2 articles here, the role of the vasculature in regulating cardiac output and the importance of venous return and shock, are just very elegant and excellent articles that review the role of venous return and systemic the systemic vasculature in cardiac output. And I would encourage you to read those 2 articles. And if you can't find them, just send me an email and I'll send you the PDF that I have myself. So I like to every now and then add inspiring quotes to just kind of get us settled in for a great talk. And this is basically to try to reinforce for you that you did not go into medicine because it was easy. And there's nothing about taking care of critically ill patients in the ICU that's easy. It is challenging, but I think we all thrive with this kind of challenge. So the overview of this talk is that first I'm going to define for you what circulatory failure is, and then we're going to go through a broad differential diagnosis of circulatory failure. Then we're going to get physiologic, and we're going to talk about the hemodynamics of shock. After that, we're going to talk about how to initially approach circulatory failure when you are the intern or the resident and you are seeing a patient who is becoming hypotensive on you on the floor. And then finally, we're going to tailor the therapy to the specific types of shock that a person might have that you're taking care of. So circulatory failure, the definition. Basically, what circulatory failure is inadequate cellular oxygen utilization. And that could be for one of 3 reasons. You could either have insufficient oxygen supply, inadequate cardiac output. You could have excess oxygen demand, septic shock with large production of lactic acid. Or you can have, in septic shock as well, inadequate oxygen extraction. And shock, the term shock, is really the clinical expression of circulatory failure. So diagnosing shock, and so when I think of diagnosing shock, you want to think of the big 3 things. That's going to be hemodynamics, the clinical signs and symptoms of hypoperfusion, so doing a physical exam on your patient, and then also looking at some basic laboratory values. So as far as hemodynamics, the first most obvious thing when you're worried about shock is that the patient typically has systemic arterial hypotension, a low mean arterial pressure. However, it doesn't have to be the case. We usually start worrying when the systolic pressures go below 90 or the mean arterial pressure goes below 70. It's typically associated with tachycardia. But hypotension in and of itself is not sufficient for diagnosing shock, and that's where the other part of the big 3 come in. So what are you looking for on physical exam? So easily you can look at the patient, you can assess their mental status. Are they confused? You can feel their skin. Is it warm or is it cold? Is it clammy? Are they cyanotic? And then you can also assess their urine output. And typically, when someone starts to have less than 30 cc's per hour, especially if they're already in the ICU, you start to worry about inadequate oxygen delivery and low cardiac output. As far as biochemical signs, the one I want you to remember, and the one I think most of you always think about when you're looking at shock, is the lactic acid level. And the normal lactic acid should be around 1. If it starts to get above 2, that would be a sign that a person is developing shock. So the broad classification of shock is kind of broken down into these 4 categories. You have distributive shock, with sepsis being the most common cause of distributive shock, cardiogenic shock, hypovolemic shock, and obstructive shock. So let's go a little bit deeper into the differential diagnosis and then talk about what the prevalence is for these different kinds of shock. So as far as distributive shock, I've already said that sepsis is the most common, but there are other forms of distributive shock. This is vasodilatory shock. Other causes include anaphylactic shock, adrenal crisis, and neurogenic shock. Typically, 2 of these are fairly easy because a patient who's got a spinal cord injury, that's the kind of patient you're going to see with neurogenic shock. And typically, someone with anaphylactic shock, there's going to be some signs or symptoms that suggest that. For instance, hives or swollen lips, the recent exposure to penicillin or another antibiotic. Adrenal crisis can be quite humbling, and you do have to be on the lookout for that, and that's one that's often challenging and missed. Cardiogenic shock, the most common are going to be acute myocardial infarction or ischemic or non-ischemic cardiomyopathies. You can also have valvular heart disease as a cause of cardiogenic shock, and you can also have myocarditis. Hypovolemic shock is quite simply either internal or external fluid loss, and this can be both hemorrhagic and non-hemorrhagic hypovolemic shock. And the big 3 of obstructive shock is pericardial tamponade. You can have a saddle or a massive pulmonary embolism and tension pneumothorax. Another cause of obstructive shock that's not listed here is an aortic dissection. So there was a study in the New England Journal in 2010. It was a large, well, by ICU standards, a very large randomized controlled trial that looked at comparing norepinephrine to dopamine as first-line agents. And we'll get into the results of that study later. But there were over 1,600 patients in this randomized trial, and there was a fairly open eligibility criteria. So there were many comers in this study. And the prevalence of the different shocks in this study were as follows. By far, the most common cause of shock in this study was septic shock, with a little over 60% of the patients, all the patients enrolled in the study, having septic shock. Cardiogenic shock and hypovolemic shock both came in at about 16% in this large trial. And then the other causes of distributive shock collectively made up 4%. And obstructive shock is quite rare, only making up 2% of all the causes of shock. Now, for you guys who are going to be mostly in the intensive care unit and specifically in a MICU, you are going to find that septic shock is by far going to be the most prevalent form of shock you encounter. And if you don't know what's going on, that is the one that you should put your chips down on. Now, how else can we think about coming up with the differential diagnosis of shock? Well, we can think about various mechanisms. So one way you can look at shock is by classifying them into different categories in relation to cardiac output and high systemic vascular resistance. So the shocks that are going to be associated with low cardiac output and high peripheral vascular resistance include cardiogenic shock, hypovolemic shock, and obstructive shock, with the outlier being distributive shock. Distributive shock, especially early distributive shock, like early septic shock, is going to actually be associated with a high cardiac output and peripheral vasodilation and low SVR. And on exam, you're going to feel people, they're going to be warm, they're going to be sometimes edematous, lower extremities, and just very different than the other forms of shock when you have someone in early sepsis. Another way to look at shock is you can look at their neck veins. So I find that to be quite helpful. If someone has very prominent neck veins and they're hypotensive, you're really either going to have cardiogenic shock or you're going to have obstructive shock. And obstructive shock is really going to go up on my differential, and I'm going to want to exclude those causes. Flattened neck veins, you're in the hypovolemia and the distributive shock category. And then we can look at shock, and we can sample your central venous saturation. People who have a high central venous saturation, over 70%, sometimes even over 75%, that's classically going to be something you see in distributive shock. Where in the other three forms of shock, cardiogenic, hypovolemic, and obstructive shock, you're going to see a low central venous saturation. This central venous saturation is best sampled from an upper extremity central line, specifically in the SVC. Although you can use a femoral line, you're going to probably end up with lower central venous sats if you sample that. So like ARDS, shock is a syndrome, and there are many possible pathological processes that can cause it. Nevertheless, it's the final pathway that often, if it's not treated correctly and promptly, will progress to multi-organ failure and death. And this is a slide that I want to show you that gives you a broad perspective of the interplay between the various forms of shock. What I want to call your attention to is that all these forms of shock are not mutually exclusive. For instance, if you look at septic shock is going to have components of it that are hypovolemic. It's going to have components of it with cardiogenic, and then certainly it's going to have components of it that are distributive. I know this slide looks confusing and complicated, but the reality is that the commonalities between these various forms of shock really make the initial therapies very generalizable and simpler. So the second part of this talk, we're going to spend some time discussing the hemodynamics of shock. The most important thing when someone's in shock is to try to get adequate oxygen delivery. And the way you get that is by effective cardiac output. In medical school, and you can ask any medical student, what is cardiac output? And they will reflexively tell you, cardiac output is the heart rate times the stroke volume. And that's absolutely true. My next question for them is then, when someone's in shock, why don't we just put a pacemaker in them and turn it up to 200? Does that increase their cardiac output? And of course, right away they say, well, no, because you wouldn't have any time to fill, and so it would affect your stroke volume. And you can see the relationship here, right? That heart rate and stroke volume are inversely related. So the thing we really need to think about is what determines stroke volume, because that's really going to be a very important determinant of the cardiac output. And the three things we're going to talk about in more detail that determine a patient's stroke volume are the preload, the afterload, and cardiac contractility. So let's define those in more detail. So preload is defined as the length of a muscle prior to its contraction. And it's really a measurement of blood return to the right side of the heart from the venous circulation. So it's a measure of venous return. And it's really best determined by a measurement of the end diastolic ventricular volume. Now, we can't really in vivo measure end diastolic ventricular volume. So sometimes we use the end diastolic ventricular pressure as a metric, but it's important to know that the relationship between end diastolic volume and end diastolic pressure is not linear. So caution really is required when using right atrial pressure or the pulmonary capillary wedge pressure as markers of preload. So afterload is defined as the resistance to the ejection of blood from the ventricle during contraction. And it is pretty much the equivalent of systolic wall tension. when you have high afterload, especially in shock, that is going to put demands on the heart and decrease contractility. Some classic causes of excessive afterload include pulmonary embolism, aortic dissection, also conditions such as aortic stenosis and malignant hypertension can all lead to increased afterload, which will decrease contractility. Use of pure alpha agonist vasopressors like phenylephrine or vasopressor like vasopressin also will lead to increased afterload. Now, positive end expiratory pressure is interesting and sometimes confusing for people because PEEP has opposing effects depending on what side of the heart you're talking about. So on the right side of the heart, positive end expiratory pressure, which is high intrathoracic pressure, pinches the pulmonary circulation and leads to increased afterload. Where on the left side of the heart, that increased intrathoracic pressure actually cushions the left ventricle and lowers afterload. PEEP also in patients who are not adequately fluid resuscitated will decrease preload by compressing the major great vessels as they return to the right side of the heart. Now, as far as the next determinant of stroke volume is contractility, and that describes the intrinsic ability of the myocardium to shorten under loading conditions. Things that will reduce contractility in sepsis include hypoperfusion, leading to myocardial ischemia. Acidosis can lead to decreased contractility, and those are the big ones. And then as far as increased contractility, you can see that with the use of vasopressors, inotropes, and also sympathetic activation. So this is the cardiac function, or the Starling curve, that everyone here remembers from medical school. And just very quickly, just to go over the relationship between preload, afterload, and contractility, we see the normal curve here. And what we see is with increasing preload, rises in right atrial pressure here. With increasing preload, we increase our contractility, and we have an increase in our cardiac output. Now, if you increase the afterload on the heart, you will see a drop in cardiac output. Likewise, if you decrease cardiac contractility, you will also see a decrease. If you put someone on vasopressor support or inotropes, you see that you will increase contractility, you'll shift the cardiac function curve to the left, and also anything that reduces afterload like PEEP in congestive heart failure, you can also see improvement in the cardiac output curve. But I know that everyone knows the cardiac function curve, but this is only half the story. To fully understand hemodynamics of circulatory failure, you also need to understand the venous return curve. So what is the venous return curve? Well, first, I want you to keep in mind that the circulatory system, the cardiovascular circuitry, it's a closed system. So the cardiac output or the cardiac function, the propelling of the blood through the ventricle, it really can't exceed the return of blood that comes to the right ventricle. So venous return is a fundamental determinant of cardiac function. And venous return is dependent on extracardiac properties of the systemic venous circulation and not necessarily on cardiac contractility. PMC is the mean circulatory pressure. It is the upstream pressure for systemic venous circulation. It is also the intravascular pressure that would be measured if the heart were to fibrillate. So in the absence of flow and all pressure equalizing, you would develop, all the pressures would equalize to this mean systemic pressure, which is the upstream pressure for venous return. Another pressure to define here is the right atrial pressure. This is the downstream pressure that opposes flow back to the right ventricle. So venous return here, or cardiac output, is going to be related to the difference between the upstream pressure, the mean circulatory pressure, minus the downstream pressure, and it's going to be inversely proportional to the venous system resistance. And then let's now focus on the determinants of the mean systemic pressure. So the mean systemic pressure, which is this pressure here, is determined by the compliance of the systemic vasculature. And so in sepsis, when compliance becomes much greater, the whole reservoir here expands, which would drop your mean systemic pressure. On the opposite, if you were to add vasopressors, the compliance would decrease, and this tube would become much more narrow, and the mean systemic pressure would increase. What's interesting, if you look at this model here of the mean systemic pressure, is so we talked about compliance. Then the other determinant is the total volume of blood in this cylinder, which is the VT, minus the V0. The V0 here is the unstressed volume. It's very similar to residual volume in the lung after a full exhalation. This is the volume that's left in the blood after you were to open it up to atmospheric pressure. So VT minus V0 is what we consider to be the stressed volume, and that is a major determinant of the mean systemic pressure. What you can see by looking at this is that the only role that cardiac function plays in venous return is on determining the right atrial pressure. So on this slide, we're going to look a little bit closer at the venous return relationships. So if you focus on the curve here, this is the normal curve here, you'll see that right atrial pressure is on the x-axis. And as right atrial pressure decreases back to zero, venous return increases linearly with drops in right atrial pressure to about an atmospheric pressure of zero, at which point it no longer goes up. And what happens here is if you make the right atrial pressure more negative, the great vessels begin to collapse, which creates flow limitation. The other thing you see here is the relationship of what happens if you were to increase or decrease venous resistance. So when venous resistance goes down, you'll see that the slope of this curve increases and venous return gets larger, where if you increase venous resistance by say decreasing preload with rises in intrathoracic pressure, you see that venous resistance, increases in venous resistance decrease venous return. Finally, if you were to increase the mean circulatory pressure with volume expansion, you see that venous return increases. And if you decrease the mean circulatory pressure, either through hypovolemia or by reducing the stressed volume, you also see that there is a decrease in venous return. You also see here that venous return goes to zero where the right atrial pressure equals the mean systemic pressure or the mean circulatory pressure. So putting this all together, the circulatory physiology of shock is best described by the interactions of both the cardiac function curve and the venous return curve. And the intersection of these two curves help to define cardiac output and venous return. So let's go through a few examples of cardiac function and venous return curves in various forms of shock. So the first form of shock we'll describe is cardiogenic shock. And let's just focus on right here the normal cardiac function curve and the normal venous return curve. So point A is the intersection of a normal venous return and a normal cardiac function curve. So what happens initially in cardiogenic shock is that there is a decrease in cardiac contractility, or in the case of, say, hypertensive emergency, an increase in afterload, or an aortic dissection, an increase in ventricular afterload. And what you end up with is a shifting of the cardiac function curve down here. So now we're on this cardiac function curve, and we go from point A to point B. So you can see that you can you have compensatory mechanisms and potentially an opportunity with fluid resuscitation to try to increase your cardiac output by raising the mean circulatory pressure, but this is only going to have modest impacts. And what you can see here is that any additional increases in venous return are going to have fairly modest impact on increasing your cardiac output. So what would you do next here? Well, the next step in treating a person with cardiogenic shock with a low cardiac output would be to improve their cardiac contractility. So in this case, a patient would be started on an inotrope like dobutamine, and you will see that the function curve would then shift to the left here, right here, and you would go from point C to point E. What about hypovolemic shock? So let's look at the normal cardiac function curve here and the normal venous return curve. So the first thing that's going to happen in someone with hypovolemic shock is that they're going to have blood loss. They're going to have a drop in their mean circulatory pressure. So the curve is going to shift from here to here. So you have your drop in your mean circulatory pressure. So you're going to go from point A again to point B. At this point, if you identify them as having hypovolemic shock, you're going to aggressively fluid resuscitate them, and you are going to get increases in your venous return. So you're going to get from point B now to point C. And now, in a patient like this, again, you can try to keep giving them fluids, but another thing you can also do is give low doses or moderate doses of catecholamines to try to improve cardiac output while continuing fluid resuscitation. And with that, you can go from point C here to point D. So trying to give you an idea of how these two curves interplay. Now, septic shock is probably the most complicated of the forms of shock when it comes to these two curves, because in septic shock you can have a combination of hypovolemia, you can have decreased cardiac contractility, and you can also have vasodilation, which drops the stressed volume of the systemic vasculature, dropping your mean systemic pressure. So again, let's start at the normal point, which is A, so we're at the normal part of the curve. And so the first thing that happens in septic shock is we're going to have a drop in the systolic blood pressure. We're going to have a vasodilation, which is going to increase the compliance of that systemic vasculature, and we're going to have a drop in our mean circulatory pressure. So the patient here is going to go from A down to B, right here. Now, interestingly, because of that vasodilation, there's also a drop in venous resistance. And if you remember, the cardiac output is equal to the difference between your mean circulatory pressure minus your right atrial pressure, but it's also inversely related to the vascular venous resistance. So when the venous resistance goes down in shock, you're going to have a slight rise here of your venous return. So this almost happens kind of all in hand. So you drop to B, and then you come back to C. What is the treatment of someone with septic shock? Well, it's aggressive fluid resuscitation. In fact, exuberant fluid resuscitation. So we're actually able to get ourselves with aggressive venous return back on this curve to point D. We have actually increased our cardiac output. In some forms of septic shock, though, cardiac contractility will go down, and patients can fall to E. And in about 20% of patients with sepsis, unfortunately, cardiac contractility can become very severely reduced and refractory to both catecholamines and further fluid resuscitation, which you see here when you go from E to F. So that's the end of trying to go over some of these this concept of hemodynamics in shock, and I encourage you, if you're interested, to go to the textbook reference. It has an outstanding review of this. It probably explains it in more detail, as well as those other references for those who are more interested. Now we're going to go to the third part of this talk, which is the initial management of someone with shock. And Dwight Eisenhower, who was both the lead commander of the Allied forces for the invasion of France, and also our president, had a famous quote where he said that in preparing for battle, I have found that plans are useless, but that planning is indispensable. And I think that in an intensive care unit, preparing for shock is very similar to this. It's very important when we have a patient with evolving shock that we are planning for everything, that we have adequate communication, that the nurses know that, hey, we need to get set up for an arterial line. We're going to need to get a central line. We need fluids. We might need to prepare for an airway. Call pharmacy so that we can get the blood ready for this hemorrhagic shock patient. So communication and planning is essential, because sometimes what you're doing won't work, and you have to be prepared and ready to do something else. Now, the other way, though, to look at the initial approach to a patient with evolving shock is the classic credo for interns is to basically shoot first. You have to ask questions later. So you're going to be asked to do a lot of management before you're going to have time to think. Now, the good news, like I said before, is that all these different forms of these shock, these 4 different forms of shock, have a lot more in common than they have differences. And so in your initial approach to all of these, you have some immediate goals that are generalizable to all the different forms of shock. So here is a list of the immediate goals in shock. So once you identify that someone has inadequate oxygen utilization, you need to get their blood pressure up. You want to get their goal map between 60 and 65 millimeters of mercury. You want to increase their cardiac output, often greater than 2 liters per minute. Their cardiac index to greater than 2 liters per minute per meter squared, which usually correlates to a central venous oxygen saturation of about 70%. You want to make sure that you have good arterial oxygen saturation, goal O2 sats greater than 92%. Your goal is to try to normalize their lactate, especially if it's elevated. You want to do aggressive resuscitation to try to get that lactate down. And if someone's not in renal failure, you want to maintain urine output. Typically, they say 0.5 mg per kg per minute, which to me, it translates out in most people to about 30 or 40 cc's an hour. I don't want to go below 30 cc's an hour in the initial treatment of shock. So in a problem-oriented approach, I tend to say, everyone with shock is a VIP. So I want to be thinking about VIP. I want to be thinking about ventilating, infusing, and I want to think about pumping in each of these patients. So let's look at this VIP in detail. So every patient with shock, you need to assess and make sure that they have adequate oxygenation and adequate ventilation. So first step is to give oxygen. The pulse oximetry might not be useful because patients might be clamping down, especially in causes of shock with increased systemic vascular resistance. So get an ABG. And with the ABG, you can assess not only their oxygenation, but also their ventilation. Are there excessive metabolic demands on this person? Are they developing a metabolic acidosis? More importantly, are they fatiguing? Are they getting respiratory fatigue? Are they starting to have a respiratory acidosis on top of a metabolic component? Patients who have pHs less than 7.0 with shock and hypotension, these are not patients who are going to do well on non-invasive ventilation. In fact, shock and non-invasive ventilation don't mix. I think patients who are evolving should be intubated and intubated early. It will lower the overall demands on the body to get them kind of intubated and sedated. Of course, when you intubate them, make sure that you give them low tidal volumes and lung protective ventilation. Interestingly, after you intubate the patient, if it's hard to keep their blood pressure up in the immediate post-intubation period, that usually suggests a very low venous return. And those are patients that, that you are going to want to give fairly aggressive fluid resuscitation. So infuse, the V, the I in VIP. So we want to give crystalloids. So there's been a lot of debate about the proper form of fluid to give, colloids versus crystalloids. I think right now we are still favoring crystalloid therapy. Most people in the ICU either get lactated ringers or they get normal saline. I think newer data is suggesting that lower chloride based crystalloid and isotonic fluid is the way to go. So I tend to give a lot of lactated ringers. All of them are going to need an initial rapid bolus, especially people with hypovolemic, obstructive, or distributive shock. Even cardiogenic shock, especially in the early period, will have maybe effective low intravascular volume. You might also want to consider giving them fluids. And certainly if you don't know what's going on, I would favor on giving people fluids. The typical fluid resuscitation, so sometimes if someone looks like they're having, just raging evolving septic shock, I'll probably say, give them 2 to 3 liters wide open. But in the literature, what you'll find is that, and as part of order sets, you'll see orders for writing for a 500 cc bolus over 20 to 30 minutes, with the goal that it increases your mean arterial pressure to greater than 65. And if it does, and then you stop the bolus and the mean arterial pressure drifts back down, to repeat it. And you can repeat that up to 2 liters. So what do you do then if, or during your fluid boluses, that a person's mean arterial pressure is staying below 60 to 65? Well, then you start vasopressors. You want to definitely do this in anyone with severe initial hypotension. You also want to start vasopressors to temporize the MAP as you start to get that initial fluid resuscitation in place. And then you definitely want to add it in people who are non-responsive to an initial fluid bolus. And why is this important? Well, this slide shows you auto-regulation of, let's just use the example that this is the kidney, that the kidney is able to auto-regulate perfusion to it over a wide range of mean arterial pressures. But once you start dropping that mean arterial pressure below 60, auto-regulation kind of is out the window, and patients at that point will start to develop organ failure. So it's really important to get that mean arterial pressure up, even if it's temporizing with vasopressor support before you give them adequate fluids. I'm just going to step back to the slide before real quick, just to mention, we didn't focus, we've talked a lot about the cardiac function curve, and we've talked about how as you increase preload, cardiac function goes up. And what you notice, though, is that there's always a plateau to the cardiac function curve. And so you end up with 2 components of a cardiac function curve. You end up with this fluid responsive component here, and you also end up with this non-responsive, or what I like to call the wasted preload, where no further additions of volume are going to give you any benefit in cardiac function. And I think in the beginning of resuscitation, you're probably not going to get yourself in trouble here, but it's really important to think about when to stop giving fluids. You want to kind of get to that point where you're just entering the wasted preload portion of the cardiac function curve, and you don't want to end up all the way over here. Okay. So general principles when it comes to vasopressors. So norepinephrine is really the first choice in almost all forms of shock if you're going to hang a vasopressor. And the reason why is that norepinephrine has both alpha and beta properties that make it kind of the ideal vasopressor. The range for doses, well, where I trained, we talked about it in micrograms per minute, and 10 is typically a lower dose, up to 50, which would be a very high dose. There is no maximum dose of norepinephrine, so you could just use norepinephrine alone up to doses of close to 100. That being said, most people will max out somewhere between 50 and 100. Here we dose based on mics per kg per minute, and so the normal doses range from 0.1 here to 1, but in the literature it says that you could go up to 2 mics per kg per minute. What if you're on norepinephrine and you have markers of ongoing low cardiac output? So this would be your urine output remains low, or your central venous, your mixed venous saturation remains low. That might be time to add an inotrope on top of that. Like dobutamine would be a kind of a pure inotrope, and the dosing of that is in mics per kg per minute. You start low and you go slow, because you don't really know. Even small amounts of dobutamine can have a pretty good impact or a pretty impressive increase in cardiac contractility. So you start low and then you kind of go up. You don't really get much more bang for your buck after 20, so that's kind of where you would peak it out. Now, if you're on norepinephrine and septic shock, or an unknown shock, and you start to notice that you're getting up higher and higher on your dose, the literature would suggest that you could add a fixed dose of vasopressin to that. Although, as far as improving mortality, there really was no difference. All that this showed was that patients who got started on vasopressin definitely were able to come down on their norepinephrine dose. I tend to do this, though, because I've had some success in maintaining a better mean arterial pressure when I combine my norepinephrine with vasopressin. And finally, I mentioned I was going to come back and talk about the comparison between norepinephrine and dopamine. There was a randomized controlled trial, and I think was pretty, although the primary endpoint was not obtained, that there was no mortality difference between norepinephrine and dopamine. There were enough complications of dopamine, specifically tachyarrhythmias, and in a subgroup analysis of people with cardiogenic shock, people with dopamine did worse. So right now, norepinephrine is preferred to dopamine. The unusual circumstances where you might consider dopamine is people with severe pulmonary arterial hypertension at baseline, or people with profound bradycardia. You might consider starting dopamine over norepinephrine, but even in those cases, you could try norepinephrine and see what happens. I didn't mention phenylephrine here. It really doesn't have much of a role in treating shock. The one time we do use phenylephrine is sometimes as a third pressor. If someone's really just profoundly hypotensive and you just feel like they need 24 hours of aggressive critical care before you were to consider stopping or maximizing your care. And also in patients who are developing pretty significant tachyarrhythmias on Levophed, or on norepinephrine or dopamine, you might change them to phenylephrine because it tends to have a reflexive decrease in the heart rate, so it tends to not cause as much tachyarrhythmia. Phenylephrine is also often used in patients who have hypotension related to sedation, but those are not patients traditionally who have shock on top of the hypotension. I'm not going to go into this slide in any detail other than to show you for your own review. You can either pause this lecture and take a look at this, but it basically goes over the various doses of the more common vasopressors, and it shows what their impact are on various parts of the heart and the peripheral vasculature, and you can review that on your own. So just some final thoughts on this initial therapy. So if you start to have to increase your vasopressor support, especially early on, it's time to achieve central access. I prefer a triple lumen over a PICC line because you're able to measure your central pressures much more accurately. If you start to go up on your vasopressor requirements, I think it's time for you to get an arterial catheter in. And those catheters are a lot easier to get in when you actually have a blood pressure. So while you still got it, you might as well go for it. Especially in people with hypovolemic shock, arterial monitoring is very important. What about the role of bicarbonate infusions or amps of bicarb? So in a pure metabolic lactic acidosis, a pure anion gap acidosis, there really is no role for bicarb. It's been studied, and really there's not only no help, but there actually is some suggestion that there's harm in giving patients with lactic acidosis bicarbonate. One of them is that rapid changes in your pH might minimize your ability, so your oxygen saturation curve shifts to the right to improve release of oxygen in the periphery, and by changing that pH rapidly, you might minimize that. Also, bicarb, when given as a substrate in lactic acidosis, increases CO2 production, so you might even make your ventilation worse. If you are going to give it, I guess reserve it for people who are developing profound acidosis, refractory hypotension, and you just can't keep their blood pressure up and they're about to code. That's probably the person that you give it to, but if you're giving that, you have bigger problems on your hand. Now, if you have a non-GAP acidosis as part of your acid-base status, you can give them bicarb, and in fact, if you want to, that can be your low chloride crystalloid of choice if it's done in an isotonic fashion. So that is the initial approach. So now you don't know exactly what's going on as far as the cause of shock, but you've done your initial get the map up, get them some fluids, and now you get to step back and think a little bit. So now we ask ourselves what's going on. So we have a person with arterial hypotension. And then we look for signs of hypoperfusion, and let's just say in this case there are clearly signs of hypoperfusion. So we have tachycardia, we have an elevated lactate, we have a patient who's confused and altered and with decreased urine output. So the next step is, yes, they have circulatory shock. So there's a couple things we can do. We can either clinically try to assess their cardiac output, either by, if we have a central axis, measuring a central venous saturation, or just clinically looking at capillary refill or other signs or markers of increased cardiac output. And we can separate people into those who have a normal cardiac output and those who have a low. And in the low group, then we can look at their central venous pressure and we can measure and see if it's low or high. And so then we end up here with our differential, a nice differential. So in patients who have, in whom they're in circulatory shock, circulatory failure, with high cardiac output, you're really in this distributive shock category. The most of those are going to be septic. In this low cardiac output with a low CVP, you're in your hypovolemic category. Your high CVP with a low cardiac output, you're either going to have cardiogenic shock or obstructive shock. And now you can see we're getting to what I think is now becoming a more and more utilized modality at the bedside in patients who in the ICU, which is bedside echocardiography, or a bedside echo, to help you work out your differential diagnosis. So I don't expect the house staff to be experts at this by any means. I'm certainly not an expert myself, but this picture just shows you the various positions that you can put people in to look that the positions to do a bedside echocardiogram, and I would just focus your attention on two of these views. One is the apical view, which will get you a nice 4-chamber view. And then the subcostal view can also get you a look at the 4 chambers, and more importantly, it can get you a look at your IVC. So just a couple of examples to run through, just to show you kind of what you're looking for when you're doing these bedside echoes. I'm not going to show any films here. So this is a patient. You do an apical 4-chamber view, and what you see here is that this person's got a very dilated right ventricle. This is someone who you're concerned about maybe having a pulmonary embolism or right heart failure, maybe related to pulmonary hypertension. This is someone with hypotension, shock, with a low SVR and a high CVP. So in this 4-chamber view, you see this black fluid surrounding the heart. So this is a person who has a large pericardial effusion with tamponade physiology. In this case, you put the probe on and you see this dilated left ventricle that's not working. This is a person with cardiomyopathy. Excuse me. And then also what you can do is with that subcostal view is you can get a good look at the IVC, and in this case, the IVC is dilated. And so this is helpful in understanding if someone's already fluid overloaded or, say, in septic shock, determining if someone has adequate preload. So the final part of my talk, and I want to thank you for sticking around for this whole talk, is that I'm going to talk about tailoring therapy to a specific form of shock. And again, my approach today, my approach with this lecture was to give you a broad overview of circulatory failure and not necessarily go into the specifics or all the data when it comes to various forms of the different forms of shock. But let's just quickly talk about tailoring therapy. And it always reminds me of my favorite coach, John Wooden, the Wizard of Westwood. One of his famous lines when he talked to his players is you need to be quick, but don't hurry. And I feel like it's a mantra in the ICU. So you can't hurry, because when you hurry, you make mistakes, but you need to be quick, because if you're not quick, you're not going to get the right stuff done. You're not going to get anything done. And when you start to figure out what type of shock you have to be quick at that point to get them the correct therapy. So let's look at sepsis first. So sepsis is basically malignant intravascular inflammation. We have an out-of-control infection that causes a cytokine storm and leads to a malignant vasodilatory shock. So how do we manage this? Well, I think that for now, the best thing you can do when you know that someone has shock related to sepsis is to think about your sepsis bundles. And there's this concept of the golden hour. What do we do? And the fact is, in sepsis, you need to treat them as early as possible. And so I would recommend pulling up these bundles, and if someone goes into shock, making sure that you hit all the key points. So within 3 hours of time of arrival in the ED, or them developing signs and symptoms of septic shock in the ICU, you need to get these 4 things done. You need to get the lactate measured, you need to get blood cultures, you need to get those antibiotics in. You have to get those antibiotics in. I don't have time with this lecture to go into all the different types of antibiotics, but you need to get broad spectrum antibiotics on board as fast as possible. And then you want to give them crystalloids for hypotension, especially if it's associated with an elevated lactate. And then within the 6 hours, you're going to try and get their mean arterial pressure greater than 65, using vasopressors if needed. If they're persistently hypotensive, you're going to consider placing a central line so that you can monitor preload, and also you can monitor cardiac output. With the central venous saturation, you'll remeasure the lactate. These are things that you should be doing. Now, the Society of Critical Care Medicine is having their meeting in February of 2016, and there's some new things coming out with sepsis. So just hot off the press, some new things to consider when it comes to sepsis. So the first is that SIRS is out. It's no longer part of anything in defining sepsis. Sepsis now is defined as life-threatening organ dysfunction. So sepsis is organ dysfunction as defined by a rise in your SOFA score by 2 from your baseline. If you want to look into more details about how to measure a SOFA score, their score can be found at mdcalc.com. If you have someone with septic shock right now, based on the available literature, the mortality rate is still exceedingly high at 40%. We define septic shock now as the presence of sepsis, which is organ dysfunction, plus vasopressors, plus a lactate greater than 2. So that is now what septic shock is defined as. And how do we try to identify? So we no longer have SIRS. What is a way of identifying patients who are at risk for developing shock and organ dysfunction? So this new test is called the quick SOFA, or the Q SOFA. You need 2 of 3 to be positive, and then you start looking for other markers of organ dysfunctions. You can assess a person's mental status, if their blood pressure, their systolic blood pressure is less than 100, or if their rate's above 22. If you have 2 of those 3 things, you want to do further tests to determine if someone is developing or a septic physiology involving sepsis. How about hypovolemic shock? So just to remind you of your body's ability to maintain a normal blood pressure in the scenario of ongoing blood loss. So when you lose about 10% of your blood volume, you become tachycardic, but you typically are able to maintain a normal systolic pressure because you're able to clamp down and increase your SVR. Up to 20 to 25% blood volume loss, you might have a normal blood pressure, or you might be relatively hypotensive, especially if you're a hypertensive patient. But those are patients where you really want to be doing an orthostatic, a test for orthostatic hypotension, because most of those patients will end up orthostatic. Again, these patients might not be hypotensive when they're supine, but they're going to have a very high SVR and they will start to spill lactate. By the time you get to 40% blood loss, you are markedly hypotensive, your lactate is very high. And if you're over 40% blood loss and you don't do anything about it for 2 hours, those patients, you are unlikely to reverse them with later resuscitation. The exam in someone with hypovolemic shock, these are cold, clammy patients. They tend to be tachycardic with flattened neck veins. The other thing is if you see a very narrow pulse pressure when you're evaluating a patient with shock, that should make you worry that the person has hypovolemic shock. You can do an echocardiogram. Patients will have increased contractility. They'll have overall small chambers. Patients with hypovolemic shock, like I mentioned before, I think you should have a low threshold for placing an arterial line. And vasopressors can help you in the initial resuscitation, especially if you can't get the maps up, but you do need to fill the tank. But you don't want to fill the tank too fast, and you don't want to be too exuberant. Data has suggested that keeping the systolic pressures around 100 in patients who you are actively resuscitating with hemorrhagic shock is associated with better outcomes than higher pressures. What about cardiogenic shock? So on exam, these are patients that you're going to see distended neck veins, you're going to see fluid overload, you're going to listen, and if you hear an S3 gallop, that's a concern for someone who's developing cardiogenic shock. The hemodynamics here, you have a drop in your cardiac output, you have a rise in your SVR, and typically you have a very low central venous saturation or mixed venous saturation. Patients with cardiogenic shock in the ICU, you should think about getting an urgent or a very quick cardiology consult, because you're going to want to know what are we going to do for these patients as far as inotropy. Are we going to give them norepinephrine? Are we going to start them on dobutamine combined with that? Is milrinone a better choice? There was a study in the New England Journal in 2003 that looked at using nitroprusside to reduce afterload in patients with significant aortic stenosis. So you're going to want to talk to a cardiologist about doing that. Also, the reason to get a cardiologist involved is because do these patients need mechanical support, either by use of an intra-aortic balloon pump or extracorporeal membrane oxygenation, in this case VA ECMO. Obstructive shock, so you're going to have hemodynamics very similar to cardiogenic shock, except if you see very prominent neck veins, very engorged, distended neck veins, that's a person you want to really be thinking about obstructive shock. Kussmaul sign, so if you see distension of neck veins with deep inspiration, that is a worrisome feature for pericardial tamponade. That's someone who you might want to get a pulsus paradoxus on. The other thing that you want to consider in obstructive shock is very early on getting an echocardiogram and also getting a chest x-ray because that can really help you narrow your differential, because you are going to, pretty early on, if you get a chest x-ray and an echo, if you find tension pneumothorax or pericardial tamponade, those are people for which those patients are going to need needles and drains. The other thing in obstructive shock that you might find is a massive pulmonary embolism, and those are patients who are going to need systemic thrombolysis. So as far as treating someone with a massive P, if you have a pulse, then you're going to be giving TPA 500 to 100 milligrams over an hour. Without a pulse, you're going to give 50 over 15 minutes. And very important is if someone goes pulseless and you want to give TPA, is you need to continue CPR up to 30 minutes after the dose is completed infusion. I'm just going to finish up by talking about right ventricular function in the context of a PE. So if someone has a fresh PE, they have no history of prior cardiopulmonary disease, even up to 20% of blockage of your pulmonary arterial circulation is pretty well compensated for, because your pulmonary vasculature has a very elegant mechanism for overcoming such blockages by distending and recruiting. When you get closer to a 40% obstruction, you start to have rises in right atrial pressure. When you get over 50%, you do overwhelm the mechanism. So patients who are over 40% obstruction tend to have rises in their right atrial pressure, drops in the cardiac output. If you do not have any known history of cardiopulmonary disease, the maximum you're going to be able to get your right ventricle pressure is about 70 millimeters of mercury. So if you get an echo in someone young, no history of cardiopulmonary disease, and they have an RVSP of about 70, that is someone who is maxed out, and if you don't do something about that soon, you're going to lose that right ventricle, you're going to have cardiac collapse. Now, people with pre-existing cardiopulmonary disease, even a small future blood clot is going to have dramatic changes in their mean pulmonary artery pressure. And if you ever get an echo on a person and you see an RVSP over 70, there's a component of that person's pulmonary hypertension that's chronic. So, in conclusion, when it comes to circulatory failure, I want to again thank you for sticking around with me in this lecture to the end here. So in circulatory failure, the first thing, circulatory failure is by definition inadequate oxygen utilization. There are 4 major categories: distributive shock, cardiogenic shock, hypovolemic shock, and obstructive shock. For the MICU, when you're in doubt, just go with the numbers. It's probably going to be septic shock. As far as the hemodynamics of shock, you always want to think about ways to improve your cardiac output, your venous return, while limiting complications of excess therapy. All forms of shock have similar immediate goals. Get the mean arterial pressure greater than 65, get your cardiac output up so you have better oxygen delivery, keep your oxygen saturations greater than 92%. As far as fluid resuscitation, I'd urge you to consider low chloride isotonic crystalloids. Norepinephrine is the first choice vasopressin agent, and get a bedside echo. I will leave you with a quote from one of my other favorite coaches, because you guys are all at Duke, you guys are all outstanding physicians, and you're all good. The question that you have to ask yourself is do you want to be great? And I think Vince Lombardi sums it up here that every day when you come into the hospital, you want to relentlessly pursue perfection. You want to try to have that perfect day where everything goes right. You might never get there, but in the process of trying to be perfect, you will achieve excellence. So I wish you good luck and thank you for your time.